Next up, we have post-operative phase, wherein we'll be including a pre-prosthetic phase and a prosthetic training. So, coming to the pre-prosthetic phase, the goals are very clear. We have to help them heal their residual limb. We've got to protect their residual limb if it is dysvascular, and to prevent and manage complications if any. We've got to treat their phantom pain. We've got to help get them independent in transfer and mobility. We've got to demonstrate proper positioning, educate the process of prosthetic rehabilitation, and especially begin with psychological adjustment. Coming to the assessment area, we have to be careful while assessing the patient, starting with the history. So clear patient demographics has to be included. We'll be looking for the social history, the family history, the financial history, the pre-amputation status, including their work, how they were before, and the activity level, their independence level. We'll be going to the systemic assessment, wherein we have to understand the cause of their amputation, associated diseases, the symptoms in visual, cardiopulmonary, neuropathy, or renal system, or whether there is any congenital issues, and current psychological and physiological status has to be checked, what all medications they are taking, and very important thing is to check their skin, the scar, whether the scar is healed or is it adherent or there is a invaginated flap. We have to check the lesions, the size of the lesion, the shape, whether it is open, whether it has a scar tissue, and dermatological lesions such as eczema, psoriasis, etc. We have to check whether the skin is moist or dry or scaly. We have to see the sensation, whether they can feel the sensations, whether is it absent or it is diminished, or whether it is hyperesthesia, because hyperesthesia is very common in these patients, and the graft has to be checked. We'll go on to checking the residual limb length, the bone length, the soft tissue length, the residual limb shape, whether it is conical, cylindrical, bulbous, especially the end and fourth area, and whether there are any abnormalities such as dog ear or adductor roll, which are very common in amputation. For the bone length, we'll be checking the transtibial limb, which is measured from medial tibial plateau, transfemoral limb measured from ischial tuberosity or the greater trochanter. Next up, we check their vascularity, because if there is a cause of amputation being vascular, then we have to check both the limbs. So we start off with checking their pulses at the femoral, the popliteal area, the dorsalis pedis, the posterior tibial pulses. Color of the skin, whether it is pale, whether it is red, cyanotic. Temperature, is it warmth or is it cold? Are they having any edema? If there at all it is edema is present, the circumference and caliper measurement is taken, and then the water displacement measurement is taken. Whether they have pain, so the type of pain, the location, the duration, the intensity, everything about the pain is checked. We check their tropical changes, and especially we have to assess their emotional status, whether they are accepting the condition they are into, how their body shape is, whether they've lost a lot of kgs or whether they have gained a few kilos, and are they okay with the status of their present scenario. We have to check that all. Next up, we look at the range of motion, very important for the residual limb and grossly for the other extremities. Similarly, the muscle strength, residual limb, and grossly for the other extremities and other nearby muscles that will be helping them in the recovery, and which will play a major role in helping them in the day-to-day activities. The neurological assessment is done to check for the neuropathy. Cognitive status, are they alert, are they oriented, are they confused? And again, I said pain is checked, whether there is phantom limb pain, whether there is neuroma or any incisional pain or any other causes to the pain. We look for the functional assessment, wherein we check their transfers from bed to the chair to the toilet, and transfer to the car, etc. We look for the mobility, what all ancillary support they're using. We supervise their mobility, and we look for the home and family, how the caregiver are, whether they understand the condition and help appropriately to the person, their architectural barriers, and all their environmental hazards, their activity of daily living like bathing, dressing, and grooming themselves, their instrumental ADLs including house chores, cooking, cleaning, and etc.